We had very good presentations from various levels, from the facility level right down to the community level, and I think quite a few interesting points were raised. One of the issues which was raised by Vidya was that in the SBA training, while knowledge and skills were acceptable, but there was a big gap, especially in terms of infection skills, and the participants had issues on hands-on training. And this is something very important, especially when we are talking of reducing maternal mortality. Unless we increase the competence of our team members, of our staff in the services, is not enough to just increase the numbers, but also improve the quality of the services provided. I think what Dr. Jain brought to the room was very important and fits in within what we call systems thinking, that just by introducing institutional deliveries or pushing for institutional deliveries may not change many things, because there are a lot of other factors, be it the community factors or be it the financing issues, a lot of other factors which also need to be considered to bring about the ultimate change that we want. So that was quite useful, and we had Dr. Mohan talking about how with just capacity building we can operationalize the village level committees and the society to get the village people to get involved within the health sector. Usually the health sector, as in an earlier presentation by Kabir Sheikh, how the power of the doctor is seen as a deterrent for other people, especially for the community, to get involved in the health sector. So simple measures can help the community to involve. And I think one important point that Dr. Jayaraju mentioned was about the increased turnover among the middle level staff at a district level, which compromises programs which are introduced into the district with well-intentioned, very well planned out, but ultimately their success may not be as much as expected, because you have the nodal officers, the taluk health officers and the program officers getting transferred every 6 months, every 1 year, and so the continuity of the program is lost. So very good presentations. I would now like to just request for about 3 or 4 comments or questions from the floor, and then after that we would like to close. Yes, Dr. Giridhar Babu.
My question is to Dr. Jain, one question and then one to Dr. Mohan. Dr. Jain, if you look at linking this continuum of care also, especially institutional delivery, to the infant mortality also, if yes, what were the findings, especially in terms of timing of the deaths? And to Dr. Mohan, whenever the interventions are done, it is shown that the results are very good. What would be your generic recommendations if it has to be scaled up for the entire state or the entire country in terms of your own interventions experience?
Okay, thank you very much. Yes, the lady.
So I'm Dr. Latika from NIE, Chennai. My question is also to Dr. Animesh. I just wanted to know, in your study, did you include the counseling component that the mother or the family members received at discharge from the institutions? Because don't you think that also plays an important role or has an impact in the childcare practices subsequently followed by the family?
Yes, Dr. Bali.
My question is to Dr. Mohan Raju. Before I ask this question, I want to congratulate Mr. Animesh Jain for his beautiful presentation. He brought out so many issues, so many findings which would be really attractive to the policymakers and planners. Particularly, the one finding I was very much impressed was the ANC examination. Most of the women, they went to private doctors rather than to government doctor. So they went, only 20% went to private government doctors and 40% to private doctors, where they have to pay. Then it's a very important issue. We planners and legislators and policy makers to look into that. My question to Mr. Mohan Raju is, he brought out two issues. One, the per capita health expenditure is lowest and out-of-pocket expenditure is the highest in Karnataka. I would rather wish to know, I will know from him, what are his suggestions to reduce the out-of-pocket expenditure? Thank you.
Yes, Dr. Keshav Raj.
I am Dr. Keshav Raj from Tumkur district, working as a medical officer. It's a question for Dr. Mohan Raj. Just with facilities, by getting an EMOC trained people or any short course trainees for a medical officers, will it fulfill the needs of a public as a specialist? That's one question. And another thing is, many of the things have been given to the NGOs for monitoring or some other things. And many of the programs which have been incorporated in the health systems in Karnataka is not on basis of the public demand, or by research work they have made the things and they have put into the as a program. No research things have been taken, or the public demand has been taken for implementing, and depending on the area basis. And second question is for Madam Vidya Patel. Just she told that the knowledge and the skill evaluation staff nurses over in A&M, why we can't take a staff nurse, qualified staff nurses as a staff at the subcenter level, grassroots level for the clinical portion, and for the programs implementation in the field by an A&M? Or can the education entry level can be increased to the PU or degree level, even at the A&M level? That is this question. And another thing for Dr. Animesh Jain, just an institutional delivery doesn't just gives a number, increase in number in institutional delivery compared to home deliveries. But is many of the charts showed me, slides showed me, even in a home deliveries and a meager without intervention by any institutions, almost it is same as that of an interventions. So efficacy between a government staff nurse or government doctors or any facility in a government sector with many of the trainings and reorientation programs versus health facilities at the private institution without training or any home deliveries, without interventions or without any reorientation courses for public in the private sector, is there any differences? Can it be a question to the strengthening the health system management?
Thank you. And we'll now, I hope the panelists have taken down their notes. So we'll start with Dr. Mohan Raju.
Dr. Giridhar Babu, was that question for me or Mohan? Okay. Okay. No, he is not Dr. Mohan, he is Mr. Mohan. Okay then. In that case, I think I will answer the questions posed to me. I think suggestions for reducing out-of-pocket expenditure, sir. This entire conference is about reducing the out-of-pocket expenditure. That is why thinking is going on in the fashion of bringing a universal health coverage, which ultimately the financing of the health care will be done almost to 100% by the public facility, that is by the government. So when such a thing materializes, probably the out-of-pocket expenditure will come down and every person will be having access to every kind of minimal health care at any facility for that matter. So the essence of this conference is about reducing the out-of-pocket expenditure. I think probably Devadasan can add to that. Then EMOC and LSA is becoming the mainstay of specialist care in Karnataka. this is only the interim measure. As I told you, as I brought out in my presentation, we have an acute dearth of specialists, especially in the field of gynecology, obstetrics, pediatricians and anesthetists. It is more telling in those fields. So, training our MBBS doctors in EMARC and LSCs has been only an interim measure. If I can give you as the project, ex-project director of the state, an example of what is happening in the state, remembering about 4 years back, we have 176 taluks. The number of taluka hospitals which can conduct a cesarean was just 10, 12, 13, 14. Today, because of EMARC doctors, LSAS doctors, then insourcing of the private specialists and postgraduates coming back to the department, 175 of the 172 of the 196 are conducting cesarean sections. So this has been only an interim measure. It will not become the permanent stay. Permanent stay for meeting the requirements of the specialist. And monitoring given to NGOs. I don't know, I'm not getting what monitoring is given to NGOs. I think, can you please specify?
Has been given to the private NGOs and all, and they will give the informations for you as a feedback. Just they have monitored and with some reports and records.
No, it is not exactly NGO itself. It is NGO as a part of the community.
Yes, sir.
As you know, under NRHM, community participation, community monitoring, and community feedback is a very, very important pillar of NRHM.
Yes.
So these NGOs participate in the community, and as a group they give feedback upon which the system will definitely act.
So we need that it should be on the community-based programs to be implemented in the regional wise. Many of the programs which will be implemented as a general for all this, all over the India or all over the state, but it may not work in some areas, but it should be need-based and it should be on the public demand.
That is exactly what I brought out. Our policies have been ad hoc, depend on whims and fancies of the people. So it should be directly from research which has happened in a community. So that is what I emphasized in my presentation. Okay. Of course, that will occur in the future days to come. And the other question was research public demand, not taken into accountability while formulation of the policy. The same thing. Yeah. The policies have to be based on a hard ground which comes from research done in a community. Then only probably all these things will get corrected. So that is what I want to say. Thank you.
Is there any question? Yeah. Okay. Thank you. Jairaj? No.
Yeah, there is one question regarding the scale up. What is my suggestion? I think this program is implemented in entire state of all the 30 districts in Karnataka. But I am shared only the 2 district experience of Koppal and Bagalkot. But yes, and I know that from different sources, this whole capacity building for VHSs, though it is one of the very important pillar of the NRHM, this kind of a capacity building is done only in 2 states, because NRHM guideline talks about communitization, but though it is a pillar without proper foundation, absolutely they are not provided much money for capacity building for VHSC members. But Dr. Mohan Raj was then, he was the PD, and we all sat together, we have pushed hard from the government. We actually diverted the World Bank money to this capacity building. KHSRDP and also contributed for 50% of the district and also from the NRHM. So almost tune of 60 crores spent for just capacity building of the VHSC members. The last, what my suggestion would be, when we think about this kind of capacity building, we need to plan it for a long term. See, we took almost 10-12 years to build the school development and management committees under Sarva Shiksha Abhiyan. And now we are seeing the result. And it is in a process. Like place like Kerala, I know because decentralization. In Kerala, the PHC functions under the panchayat. That's an entirely different go. But here, we just can't think about. We are not even even still the community at the very nuanced level, they are not able to come out, because you know the situation in the village. The last person who community can raise a voice, that is medical. They can raise voice against police also, but not about the medical. We have seen in our entire process documented, when, sir, doctor, like typically God, finished. They can't talk anything, they can't ask any question. The people to come to Janasamvada program, they used to sit, sir, doctor ge prashne kelala. Then all the questions are forced on Ashas and ANMs. Okay, doctor is safe. So what we did, we told them, you are not asking question, don't put any personal question. You see the systematic issue, and then you take up. Then we trained the community to how to ask question. So initially doctors are against organizing Janasamvada, because they all, after 2-3 Janasamvadas, they feel comfortable. They're not asking some, because they know that there is some incident happened between doctor and the patient, they'll come and ask me, or there is some other issues. No, we not allowed that kind of a question, because we know that that is going to stop the entire process. So they started asking more supportive questions to doctor, how we can support to better function. Okay, this kind of issues they started. So then everybody started participating, because for us that moment the participation was very important. So in the scale up, my suggestion would be involve the entire panchayat system, which is at the grassroots level, in the decentralization mechanism, where we can see some kind of a result in a long run. Thank you.
Thank you for the interest that you have shown. The first question was by Dr. Giridhar Babu, and he wanted to know about the continuum of care with respect to IMR, right? And if so, what was the timing of deaths? Well, we did look into a lot of things, and including we collected data from the district health office at Ballari as well, and then we also looked, this study, let me give you a little background before I answer that. Basically, we looked at the community data, which was the household survey. We also had exit interviews, and we had inpatient diaries maintained, and then so it was a multi this thing, which, and then we also looked at the facilities which are available. We had a very comprehensive survey, including visits by the investigators to both the sites, and at a couple of months intervals, and then we did a lot of things. To give you a short answer, basically right now I don't have the figures to tell you the period or the time of death, but we did look at this thing and infant mortality rate data. And one thing I would like to add and comment, there are people here available from even from the government side and the systems. So basically we found that the data maintenance at Ballari is not very good, even in the district health office. I mean, it's not in the way we would like it to be. So it was a little difficult, and we could not really get exactly but we have got all the data, and it's the age classification is also not as per what we would like it to be. So that's something about what I would like to answer to your question. And probably later maybe I could give you more figures, because I don't have it readily available right now. I forgot the name of the doctor, the lady doctor. She asked me a question on the counseling component. I presume you're asking about when the mothers after delivery were being discharged. We had a question, in fact I didn't put it up, we had a question, not only that, even about the antenatal checkups when they went to. During that time, were they talked about the breastfeeding and practices about contraception and things like that? And surprisingly, even those who went to the institutional delivery or they had antenatal checkups, there were not many who were talked about or told about this. So counseling was not done very well. And even this was the same case, almost similar, the percentages were similar, and statistically also there was no difference. Again, I don't have the readily available figure, but I have these things available with me, and we did talk about, and this was one thing which was surprising, that they were not counseled about, and obviously they wouldn't know, and especially those who are in the poorer socioeconomic strata with illiteracy and poverty and things like that. So that's one thing. The last question I believe was by Dr. Keshav Raj about, is there any difference, if at all, between the institutional delivery and the home delivery in spite of all those trainings that are happening? Partially I think it's been talked about by Dr. Mohan Raju, but that's what I'm trying to highlight here, that even if we have institutional delivery, we do not see much of difference when we see about the practices or the health promotion related parameters. And that's what, so that's the point I'm trying to make, that it's not only institutionalization, it's much beyond that, and we need to look at that. So that's something. A few things I would just like to quickly take on, sir. Basically, it's about health-related behavior, and Dr. Mohan Raju also commented that it's not improving. I wouldn't totally agree. I would partially agree to that, but I think that there is health-related, healthcare behavior, health-seeking behavior is there, and even in this community, we see that there is health-seeking behavior. They go to private clinics, and even we have looked at the delay, where there was a delay or not. It's not that bad, but still, what is happening is probably they are not having the faith in the public health system, one thing. And we also compared it between public-private partnership, which we have in Dakshin Kannada with our institution and this place. And even we looked at the expenditure part of it. And we find that public health system actually leads to more expenditure for similar kind of illness and even for similar kind of hospital stay for a treatment compared to a public-private partnership that we have back in Dakshin Kannada district. So that's something which I think is something which we need to look at. And as you said, I'm very happy to know that public-private partnership is one of the thrust areas that you are looking at probably, and even the universal health coverage. So I think probably that could lead to some answers later. Thank you.
Sorry, I don't know I think Dr. Giridhar Babu, you raised the question to me. What I understood from your question is like the role of staff nurse. She has to be responsible for the activities at sub-center level also, and at the same time, like ANM, her role to be restricted to field level. That's what I understood, right? So in this regard, like overall from the observation, from evaluation of this SBA training, what we observed is, yes, I agree with you, but there is a need to draft state level SBA policy where like clearly identifying the role of each level of public healthcare facility and healthcare provider, because as of now there is no clarity between the role of staff nurse and the ANM. There is a lot of overlapping about their activities. So maybe what I feel is like once the state level policy gets drafted on SBA training, maybe in the clarity, this issue can be addressed. That's what I feel. At the same time, one key observation which we come across during our evaluation is like the training is being conducted for both the staff nurses and ANM together. Actually, there should be separate batches for ANM as well as staff nurses. And as again, I'm saying like there is no clarity between activities assigned to ANM as well as staff nurse. So once we strongly recommend from our evaluation that draft on SBA, separate policy for SBA training need to be drafted, where there should be clarity on the role of ANM and staff nurse. Maybe then this issue might get addressed.
Thank you very much. It's exactly 1:30. I think it's time for lunch. So we'll close this session with congratulations again to the speakers for making nice presentations, and thank you also to the audience for participating.